there are different type of quality of the stone. Okay, calcium. You also have urate, calculi. You could have calculi that are related to cysteine accumulation, and there are many other factors that can contribute to no more than the pathophysiology of nephrolithiasis is due to oversaturation. The most common cause of urinary calculi is no more than sediments present in the urine due to lack of volume. So basically, sediments, in this case, electrolytes and solutes that precipitate or oversaturate due to the presence of low volume. And that's one of the reasons why we treat nephrolithiasis with fluid. Okay? So let's start one by one. Basically, it's present in 12% of men and 5% of women. The more elderly you become, since the PTH is a malfunction and all that, you tend to have alterations of calcium and phosphate, and that could be a trigger factor. Sometimes the position of urine crystals that, for example, patients that have gout, regardless of the other risk factors that the patients can have and age or gender, can also produce urinary calculi. But the most common pathophysiological process that leads to nephrolithiasis is supersaturation, which is, again, as I told you, increased amount of solutes precipitating compared to the amount of water that the patient has in the urinary system. So when you don't drink enough water, which I also tend to forget to drink plenty of fluid, your bladder and your urinary system tends to accumulate solutes and they calcify and produce a stone. Okay? Sometimes alterations at the level of the pH can provoke a risk factor for urinary calculi. You would see, for example, when the patients have an acidic pH, they tend to have more urine crystals accumulated regardless if they have a history of gout or not, okay? And when the pH tends to be more alkaline, patients tend to accumulate calcium and magnesium, okay? So the pH of the urine is an important factor. Another factor is genetic predisposition. So you can have a familial predisposition, it could be a hereditary condition that basically the patients have lack of an enzyme, which is called uromodulin, that avoids the precipitance of solutes in the urine. So again, major risk factors, drink plenty of fluid. Okay? So you could basically eliminate the excess of solute in your urine filtration. In addition to that, for example, patients that have hyperparathyroidism that tend to accumulate calcium byproducts and phosphate. In this case, of course, will be hypophosphatemia and hypercalcemia. Any disease process that produces hypercalcemia can produce urinary calculi. As I told you, family history. Sometimes when you have an infectious disease, in this case UTI, the citrus basically is a byproduct, is basically by citral. That's the reason why it was created a medication for that. Normally, the citrus level in our urine tries to eliminate the bacterial endotoxins that could provoke calculi. So UTI is a risk factor for sediment increasing. Do you understand what I'm trying to say? Mm-hmm. And produces urinary calculi because the levels of citruria is diminished when you have any UTI. Okay? So having renal tubular acidosis, which again, acute tubular necrosis or renal tubular acidosis is a precipitating factor not only for intrarenal renal failure, but having intrarenal renal failure, which is a prolonged hypovolemia, will increase the sediments in the urine and can precipitate urinary calculi. As I told you, hyperparathyroidism, gout. Why prolonged immobilization? When you have prolonged immobilization, the patients tend to have hypercalcemia because there's a high extraction of calcium from the bone into plasma. So again, any disease process that can produce hypercalcemia can produce urinary calculi as well. The same principle is with oxalate, which precipitates calcium formation in the urine. Enteric diseases, again, remember that when I explain here the PTH, I put GI, bone, and kidney. So any gastrointestinal disease that can give you malabsorption, induces malabsorption of calcium, therefore accumulation of calcium in plasma, hypercalcemia, and therefore urinary calculi. Every single factor that produces gout that can increase uric acid formation. So if you have any alterations of your xanthine metabolism, you will increase uric acid formation and therefore urinary calculi. And as I told you, UTI is a factor that, or risk factor, or precipitating factor for urinary calculi, because again, not only you are lacking citrus, but in addition to that, urea splitting byproducts that we normally have in our flora of the urinary tract system is depleted, therefore patients tend to form high levels of sediment. Okay? Now, the most common type of urinary calculi is calcium. And that calcium type of urinary calculi could be calcium oxalate or calcium phosphate. Okay? Now, what are the risk factors for calcium accumulation in blood and therefore high sediments of calcium in urine? Well, hypercalcemia. Any disease process that can give you hypercalcemia, such as mentioned, hyperparathyroidism. If you have hypothyroidism, can do it as well. Because if you recall, the calcitonin is released in the thyroid, and the calcitonin is activated when you have hypercalcemia. So therefore, if you have hypothyroidism, your calcitonin will be decreased, therefore you have hypercalcemia and can induce urinary calculi. So hyperparathyroidism, hypothyroidism, or, for example, immobilization. Any disease process or renal failure. Didn't I say that if you have renal failure, you cannot reabsorb properly amount of calcium and phosphate? So those can precipitate and can produce urinary calculi. Even though UTI is highly prevalent for struvite type of calculi, which is another type of calculi, having low levels of citrus or hypocitruria induced to UTI can also precipitate calcium. But I want you to remember hyperparathyroidism and one of the leading causes of calcium accumulation. Do you understand? Good. Another type of calculi, and this is based on percentage of presentation. So from the most common to the least common, okay? So another type of calculi is cysteine, okay? It's just another amino acid. Magnesium, which again, magnesium type of calculi are produced by either having hypocitruria or by having so much infection repetitively in the urinary tract that your urea splitting byproducts, which is no more than the normal flora present in the urinary tract, is lost. The same as if you're having a lot of diarrhea, that your intestinal flora gets lost. When you have recurrent UTI, your flora in the urinary tract is lost, and that flora is in charge of eliminating urea. And therefore, you tend to accumulate magnesium, and you can provoke urinary calculi. And another one, which is of course more common than these two, is uric acid due to gout, most common. Okay? But remember, the pH also participates on that. Having a very acidic pH in the urine can induce, for example, uric acid, and having an alkaline more commonly calcium and magnesium. Okay? Again, the most common is calcium-based urinary calculi. And because it's calcium-based, they are radio-opaque. You can see the urinary calculi based on calcium in a simple KUV. So it is common sense that in medical practice, unfortunately, we act or we treat the patient based on the most common etiology, even if it's given or not, even if you know it or not. Even if in an exam, I don't tell you what to do first, you should act first and treat the patient first based on the most common etiology. And if the most common etiology is calcium-based byproducts producing urinary calculi, since this calcium is able to be visible or shines or light up, what's the color of your bones in an x-ray? White, right? So why is white? Because it has calcium. So the urinary calculi with calcium-based, either calcium oxalate or oxalate, will light up in an x-ray. It is not the gold standard diagnostic evaluation, but the initial could be a KUV, and the majority of the calculi are calcium-based, since it's the most common, are radiopaque and could be visible. Okay? Any questions so far? Clinical presentation. I have had urinary calculi because I don't really know fluid.
What's the gold
standard? Even though I
standard?
know it, I keep doing it.
What's the gold standard test for?
Hold your horses. Step by step so you don't get confused. Okay? So, the most common symptomatology is flank pain that radiates to the groin, to the labia in the female, to the perineum or the scrotum in the male. Could it be a testicular torsion? Of course. Could it be epididymitis? Of course. But always think about the most simple diagnosis first before. I'm not saying you're not going to do a testicular ultrasound, but think about urinary calculi. And mostly when this pain in the flank is colically in nature. You don't have intestine down here, right? No. So if it's like wavy type, like comes and goes in this pattern, which is felt, sometimes the patient will tell you, it's like I'm trying to go to the bathroom to poop. It's like squeezes and then let's go. Severe pain, and I can tell you it's described in the literature, but I've had it, and it's worse than labor. Associated with nausea and vomiting. And as it approaches the urethra, the more distal area to excrete it, it hurts the most. And of course, the radiation really determines where the calculi is present. Because when you have it at the level of T10 more or less, this is just for you as an understanding, you're not going to have radiation to the groin. As it goes down, migrates down, of course you're going to have more and more radiation. Okay? Could it be associated with microscopic hematuria or macroscopic hematuria? Yes. So this is one of the causes of hematuria. Nausea and vomiting, and I can tell you how I get it first. I know that I'm going to get an attack because I have cystitis first, and then I'm getting the pain a day after, for example. So it could be associated with dysuria or urgency. Mostly when you have it close to the urethra. Even though it's less common, that's my presentation. So for example, this is a 34-year-old that comes to your office complaining of severe flank pain that began in the morning. The pain comes and goes in waves. Nausea, vomiting, And even though he hasn't had any changes in urination, now the pain resolved. I just want you to look at the risk factors. Well, hypertension on atenolol is not a risk factor, but if the patient, for example, is treated with diuretics eliminates volume, and if the patient doesn't drink plenty of fluid, right, then oversaturation takes place and you can have calculitis. And in addition to that, you know that thiazide diuretics from pharmacology, one of the major risk factors is uric acid accumulation, right, and can precipitate gout, and that could be a trigger factor for urinary calculi, in this case, uremic. Smoking, not a major risk factor for urinary calculi. Patient in this case is afebrile. There's no urinary tract infection associated, even though urinary tract infection could be a trigger for nephrolithiasis. Normally, nephrolithiasis is not associated with fever. It's just an inflammatory process. Basically due to mechanical damage of the urethra and the uterus. Okay, patient appears well when in no distress, when in not in pain, because you can't touch him when I'm in pain. Most of the time, let me tell you, but I have seen patients and I have seen it on myself, the pain is one side, not bilaterally, and actually you have to bend down to be able to resist the pain, and you cannot control the vomiting. Why? Because of the celiac plexus. Okay? Now, this answers your question. What is the gold standard examination for nephrolithiasis? Is the CT abdomen. Try to avoid at all costs to do it with angiogram, with contrast, because remember, nephrolithiasis is an obstructive condition that is the cause of post-renal renal failure. Why again? Because the majority are radiopaque. There's no need for contrast. Okay? What else can you do? You could do an ultrasound. Not only, basically, you could see the obstruction, you could see the calculi, but most likely you're doing an ultrasound just to rule out the possibility of this stone producing hydronephrosis and damage to the calyces. Okay? Because if a calculi is producing dilation of the pelvis, of the kidney, and the calyces of the kidneys, which is hydronephrosis, this patient cannot go to lithotripsy. This patient has to go through urethrooscopy or urethrostomy, basically going in and taking out the stone, because otherwise the patient will go into renal failure, or at least release the pressure by deviating the ureter to the outside meanwhile. Okay? So that's the purpose of that. Of course, you could see pregnancy, but you could do a pregnancy test before. KUB. KUB is the initial diagnostic examination for nephrolithiasis. Of course, you're gonna miss cysteine, you're gonna miss uric acid related, but you're gonna catch at least 80% of the calculi. So doing a simple KUB, even before you take the patient to CAT scan, is not necessary if you actually see the stone and have the appropriate signs and symptoms. And of course, intravenous pyelogram, but this is the last resource, the same as CT with contrast, because the contrast itself can damage the kidney. So initial KUB, gold standard, CT abdomen without contrast. So this is a regular KUB. This is your ascending colon, transverse, I don't know if you see the bubbles. Descending colon. Here is, if you know your anatomy, your kidneys are right here. Even though this is not supposed to light up, but you have one kidney there, and if you kind of like abstractly imagine your anatomy, uterus should go down here, right? Paravertebral. So here's the calculi. Do you need anything else?
No.
You don't need a CT abdomen if you see that, okay? With the clinical signs and symptoms appropriate for it. Here, you have one kidney, another kidney. Now, look at that calculi, look at the color of the bone. Calcium, right? But in addition to that, look at the size of this kidney compared to the size of this kidney. This is the pelvis, okay? Don't count this part. So look at that kidney size-wise, compared to this kidney. It's already producing a dilation. So this type of patient are the patients that cannot wait. Of course, you're gonna give a lot of IV fluids, but you're gonna send the patient to the OR. You know, compared to a patient that doesn't have any type of dilation of the calluses, hydronephrosis. No hydronephrosis is reported. If you don't know how to read CAT scan, no problems, read the report, even though there are many radiologists that make mistakes. So if you see any type of hydronephrosis from moderate to severe, mild, no problem, moderate to severe, that calculi has to be extracted, or at least the urine has to be deviated.
So that one does have hydronephrosis. All right.
Now, the majority, listen to this, is also reported the size. If it's less than 5 millimeters, no problem, because you can excrete it yourself. Painful, but with a lot of fluids and pain management is enough. But if it's more than 10 millimeters, you would not eliminate it unless I will bring down the size of that stone, right? In many particles, which lithotripsy would be one of the treatments, right? Or I actually go ahead and extract it myself during surgery. Now, even though IV fluids and pain management is sufficient for a patient that has less than 10 millimeters calculi and they can excrete it by themselves, what else can I give to the patient to help increase the motility of the ureter and therefore eliminate the calculi faster? Alpha blockers. The same that you use for BPH, for benign prostate hypertrophy. You could use doxazoxide Cardura. You could use any alpha blocker. Okay?
I thought they were given to dilate.
Both. Dilates, but also increases the
I
motility.
didn't know about
All right? So what are you going to give to the patient? Well, first of all, this cannot be done outpatient, even though I never went to the hospital. I never go to the hospital. I have IV fluids at home. I do my own health. When I go to the hospital, I have a very high deductible, $6,000. Right? And they don't care if you work there. You gotta pay. I am not. I canalize myself. If I have to inject myself, I inject myself.
You know what? Kendall Regional is the most expensive hospital in Florida.
Who?
Kendall
Because
Regional.
of trauma and burns. And we have a lot of prisoners,
I know it's not profit, no?
which is a lot of money for the hospital.
That is
And the prices are
It's
ridiculous.
profit, it's profit, Jackson.
So fluids, and more than 2 liters of fluid you have to excrete. Basically, you put the patient on a bed, an IV fluids, pain management. Yes, please, this is very painful. I can assure you, I'm not here for opioids. It's painful. All right? So, in addition to that, from the first day, give them Flomax to be able to, yes, dilate and excrete faster, okay? I've never seen any sediment in my urine. I haven't strained it. Like the book says that you could strain it and send it to the laboratory to see which type it is. I don't care. It hurts a lot. And I know the risk factor because I do my annual physical and I know that I don't have any of the diseases that can put me at risk. I don't drink sodas, but I drink a lot of coffee and I don't drink enough fluid. That I don't have. Now, even though NSAID could be enough for the treatment of or pain management for moderate, it doesn't help. But in addition to that, remember this is an obstructive condition that can give renal failure, and NSAID will decline out of regulation. So be careful with indomethacin. Toradol is another one, yeah. So, and of course, you only hospitalize if you see hydronephrosis. I don't know if I have hydronephrosis or not, but I don't have renal failure, so most likely I don't have hydronephrosis. So what will you do? Basically, the laboratory exams that you see here listed is to rule out etiologies, because it's not only to do what I do, get rid of the stone with IV fluids and pain management and just keep going. Try to eliminate the causes, right? And if it's not fluid intake that is inappropriate, then you have to look for underlying diseases. So what are you gonna see in the CBC? In the CBC?
No, anemia.
Anemia can give you nephrolithiasis?
You don't see anything.
No. So what can you see? What about UTI? So leukocytosis, right? So at least you can see leukocytosis that could make you think that dysuria that the patient is having could be related to a UTI, which is a trigger factor or risk factor for urinary calculi. What about BMP? Yeah. What about uric acid, right? Urea. What about the calcium level, the phosphate level, right? Magnesium, etc. And of course, urinary calculi, that is normal to see microscopic hematuria or macroscopic hematuria, but that has to go away after you pass the storms, right? Because otherwise, that means that if the hematuria continues, that means that most likely you develop hydronephrosis and it's already producing sclerosis, okay? And of course, as I told you, CT abdomen is the gold standard examination. So,
sorry, the previous slide said non-obstructing stone. So what if you have a patient that presents to the ER with, the pain and everything, and the CT shows an obstructing stone, and you're giving the fluids and everything?
you won't pass it.
Okay, so that patient requires intervention, more so than just, okay.
Now, outpatient, you can coordinate lithotripsy, but if the patient is already having a dilated ureter that is producing reflux and hydronephrosis by an ultrasound or even by CT, you see hydronephrosis, you can wait. It doesn't mean that you're not gonna give fluids, you're gonna give fluids, but you have to coordinate with a urologist to take this patient to the OR, okay? So this is basically a follow-up of the patient. You send the patient home with PO, pain medication, and instruct the patient to take fluids. Fluids. Because again, the most common etiology is oversaturation of fluids, okay? So in the first episode, of course, you're gonna confirm that the patient has a urinary calculi. You're gonna treat accordingly with fluid, pain management. You're gonna put the patient on Flomax, regardless if it's a woman or not, doesn't matter. Because I've had that question before. Or what about a woman? Doesn't matter. It's an alpha blocker producing dilation of the uterus and increased peristalsis of the uterus. Okay? And please don't forget, which is never done in the hospital, maybe just a routine CBC and BMP, but try as much as possible to strain the urine and send the urine to analyze to see exactly what type of solute do you get. If it's calcium related, try to look now for your PTH and your phosphorus and calcium level, right? So depending on the type of calculi that you get in the analysis, then you determine the appropriate exams that you're going to do collateral, okay? So increase fluids. I cannot emphasize that more because it's the main etiology for that. Now, should you restrict calcium? Let me tell you that even though the literature says that you should not restrict calcium intake, I had my first episode, and it might be a coincidence, but remember, patients are so much different than literature. You behave completely different. And even though the literature emphasizes that has nothing to do, to have a normal calcium level and increase calcium intake, I started having calcium with my vitamin D just to prevent osteoporosis because I'm getting close to menopause. I'm gonna be 50 in January, even though I'm still menstruating, but the age. So it coincided. My first episode with my vitamin D and calcium, plus of course, I am not drinking enough fluid, so that provoked more oversaturation, even though the guideline says no, doesn't matter. But if you do have hypercalcemia, of course you're gonna restrict the calcium intake, and even more, you're gonna give Vicitra, which is a calcium binder, okay? try to decrease your sodium intake because again, the more salt you add to the food or sodium containing food will arrest, will take out more water with it and the patient will get more dehydrated. So if at any point the patient gets dehydration by whatever reason, that will put the urine on oversaturation. Protein, remember, protein metabolism, same thing, increased uric acid level, right? So therefore, the higher the protein, the more uric acid production, high risk for uric acid calculi. So patient returns complaining of passing another stone. You confirm again that the patient has the stone and you do the same conservative management. Again, try to look for what's precipitating this and educate your patient. If it's sodas, if it's food that have a high levels of preservative, if it's recurrent UTI, because if you do not eliminate the triggering factor, the patient's gonna have recurrency. And the major problem is renal failure that can follow, okay? You actually have, and it's true, relapse 50%, 5 to 10 years. So at least if you're trying to eliminate your risk factors, just once you have one first episode, you have a high chance to develop another episode within 5 years. Okay? And I told you about straining the urine and try to look for factors in the blood test. Like you normally do a CBC, BMP, and your urinalysis to strain the urine, but depending on the results of the straining the urine, you're gonna go further and look for your uric acid level, look for PTH and calcium and phosphate if you're thinking about hyperparathyroidism. So what else can you do? You could do, if you can't find the cause, you could do a 24-hour urine collection and analyze the pH, even though it's reported in a regular urinalysis. And you're gonna look for all the solutes that are excreting the urine. Because for example, oxalate is not reported in a regular urinalysis the same as citrate and cysteine. So you could actually look for those factors in a 24-hour urine, okay? And mostly when the calculi do not show up on the CT, because you only see the dilation or the hydronephrosis, but you don't see the actual hyperlucency of the calculi because they're not calcium. So cysteines don't light up, uric acids don't light up, okay? So those are basically seen in the urine when you're straining, okay? So basically, calcium oxalate, as I already told you, the major disease process is hyperparathyroidism. So that's the reason why it's super important to measure PTH and calcium and phosphate, which you know that you're gonna have hypercalcemia and hypophosphatemia. Again, as I told you before, if the patient is with thiazide diuretic, that can precipitate uremia, but the guideline says, again, the main treatment is to give IV fluids, pain management, and put the patient on Flomax to be able to dilate and excrete. But sometimes you cannot excrete, even though there are microparticles of stone, even if you have done lithotripsy already, you can help as well by giving diuretics to the patient. Now, don't give thiazide diuretics if you already have a uremic calculi, like uric acid calculi, because they will precipitate it more, okay? That will be only an option for calcium oxalate or citrate, okay? Now, in addition to that, if you see your 24-hour urine that the citrus level is low in the urine, so you have hypocitruria, what else can you give? Potassium citrate. So you could increase the citrus level and avoid urinary calculi. And as I told you, if you have gout, you basically treat accordingly with, thank you, I was thinking about the word, allopurinol to be able to avoid accumulation of uric acid. Talked about that. Another condition that tends to produce a lot of urinary calculi, mostly uric acid related, You already have hematology, oncology, right? Remember that? And when the patients, for example, tend to have tumor lysis syndrome, uric acid becomes elevated, and the patients tend to have as well urinary calculi, and that will be a cause of renal failure. We talked already about allopurinol and potassium citrate for the treatment. Now, there's another type of calculi that, as I told you, patients with recurrent UTI, they tend to have hypocytruria, but in addition to that, patients with recurrent UTI tend to not have appropriate urine excreting byproducts. So the bacteria in the urine, like E. coli or Enterococcus or Proteus, cannot be eliminated properly, and they tend to have a type of calculi which is called struvite. Now, struvite, no, it's not S, struvite calculi. Yeah, Hispanic people tend to say S instead of S. So struvite calculi tend to be gigantic, enormous. And this type of calculi, it is impossible to rupture with lithotripsy or be eliminated with fluids at all. So the patients that have struvite calculi, they always need surgery, okay? And how do you know that? Look at the x-ray.
Oh my God.
It's actually penetrating in the entire pelvis and all the calluses.
So it grew like that, or accumulated like that?
Yeah, it grows over time. These are the patients that tend to have recurrent UTI, okay? So if possible, you need to have surgery. Another name for it is Staghorn calculi because of the way they're growing. Very highly common in females, UTIs, and Staghorn calculi. Another one, and again, the borderline effect is the same thing, is supersaturation. Patients tend to also accumulate cysteine, which is no more than amino acid. That's why you should decrease the amount of protein intake. But in addition to that, patients have genetic predisposition to produce cysteine when they have genetic autosomal recessive condition that they cannot metabolize amino acids properly. And it accumulates not only in the blood, but also accumulates in the urine, and they tend to have cysteine calculi. So it could be a familial predisposition or genetic. So back to baseline, what do you have to do? Analyze the stone. So it's not only what we're doing in the hospital. Yes, the hospital is emergency management, it's pain management. So hydration, try to eliminate the stone and go home. But as an outpatient, it's highly, highly important that you analyze that strain and send it to the laboratory and try to determine the specific cause for nephrolithiasis. Otherwise, the patient's going to have more recurrences and high risk for renal failure. Okay? We already talked about that. Any question? So as I told you, you can eliminate less than 10 millimeters. More than 10 millimeters, impossible. You will never pass it unless you break it. How can you break it? You can do shock wave lithotripsy. If the patient is having hydronephrosis, you have to do mandatory percutaneous lithotomy, which is basically no more than levating the uterus to the outside to release pressure. Most of the time, this is done in critically ill patients, okay? And or going in through laparoscopic and removing the stone manually. And of course, the patient has to be stable for you to remove the stone by laparoscopy. So, who do you admit? It's common sense that if you don't pass the stone and you continue with pain, or if you have bilateral obstructive stones, even if they're less than 10 millimeters, you're high risk for renal failure, so you have to at least admit this patient for 24 hours for observation until they pass the stone. If you have, for example, hydronephrosis, they can't go home, they have to be admitted. If at any point it has already developed acute renal failure, obstructive, and the patient has anuria, it's common sense, right? Or of course, if the obstructive stone is already producing pyelonephritis and you have infection. So all that is common sense. Otherwise, it's treated outpatient. I mean, inpatient first, and then you out. If you have the capability, which I've seen in an office, to put an IV and put fluids on a patient and give patient pain management, there's no more to do. Any questions? So we can go to UTI. What time is it? 4. You want to finish here and then we have UTI and renal artery stenosis only, or if you want to finish UTI and then we only have one and practice? Let me see how many slides. Oh, it's only 20 slides. We can do it. Where? UTI?
Yeah, I kind of want more, but it's just funny that. I don't know.
No.
It is 20, because renal
Oh,
arteries.
renal artery stenosis is longer.
That's the longest one.
Yeah, that one will be next week.
Oh.
That's the longest. But we can do UTI. It's only 20 slides.
Yeah.
So we can only have one and practice